This is the first time I've presented, so I'm actually pretty excited about it. The topic we're going to cover today can be considered fairly broad, right? It's an industry initiative that Humana is involved in, and at some point may involve a lot of the folks in the room here, because it touches a lot of different parts of the organization. So I've got probably too many slides, so I'm going to be fairly quick through some of these. But please, because I tend to talk quickly, and many times I assume that people are telepathically getting the information that I think I'm saying, and it's sometimes a really bad assumption. So if I'm confusing folks or you need to ask questions, feel free to raise your hand, and I will either say we'll cover it in a slide in a few minutes, or we'll stop and talk about it, right? A little bit of perspective, so as Chris noted, I'm Patrick Murta, I'm one of the solution architects here at Humana. I've been with the company about 20 years. The area that I work in is interoperability, so I deal with Humana's interfaces to outside organizations such as EMR systems, hospital systems, provider offices, CMS, applications, so you can see why I work a lot with these guys over here. And the Vinci Project is founded in some of the technology that Humana pioneered a couple of years ago. We were an early adopter, and we're going to talk a little bit about that, and it's quickly becoming an industry standard. So, with that being said, why am I here today? Because the Vinci Project is relatively new. It started about a year and a half ago, and I'm going to talk about some of the news articles that we've seen recently, why our senior leadership is talking about it, why folks like DH&A and the DEC and others are really excited about some of the interoperability. But first, let's talk about why I'm here, because I think, I don't know where Chris went, he's back in the back there. He actually saw an article that was on HIR that mentioned some of the work that we had done over the last couple of months, and we demoed at a big industry convention or conference down in Orlando a couple of months ago, right? So we're going to look through some of those slides in just a second, but also the project in and of itself has been discussed and actually evangelized by Dr. Beveridge, Bruce, others in press releases and other things. So I think the reason I'm here is people started seeing these articles, decided it was a good topic, and so we're here to learn about Da Vinci, right? So just a quick overview is, Da Vinci is not Humana is a partner in this, but it encompasses many different organizations, some of which we historically have considered to be competitors. So initially it was quite interesting when we were in meetings, and I was sitting beside the United guy, and the Cigna guy, and we were wondering who was going to pull the first punch. It never came to violence, but the thought did cross some of our minds on occasion. We're much beyond that at this point. We all get along. But the actual project is in the news quite a bit lately. So you see that this is a Humana article that was released back in October. This is a press release from the industry talking about, whoops. Already lost my place here. There we go. So these are some press releases, some Humana specific. This is an interesting one that we had as a result of the conference down in Orlando, thinking about using this for big data. So if you have any big data folks in the room, you're going to be interested in this topic as well. And one of the more important things that happened over the last couple of weeks, actually since Chris asked me to come talk, is some of the project deliverables have started to make their way into CMS regulations. So this is not just Humana and Cigna and Aetna and a few others talking about it anymore. CMS and others are starting to codify some of these interoperability guidelines directly in proposed rules. And that's actually one right there. I know it's really hard to see, but this little box here says Da Vinci, and that is from a rule that was published by CMS a month ago, and that it should go into effect later this year or early next year. So whether you like it or not, these provisions are coming our way, and we do like them, by the way. All right, so just some baseline terms, because I'm really bad about throwing acronyms out there and people know what I'm talking about. Many of these are going to be very, very obvious, but let me just quickly go through some of these. Value-based care. Value-based care is a really important topic as we move from a fee-for-service model in which doctors and providers are reimbursed for the number of times they see patients. If you think of that for just a second, you realize the fallacy in that model, right? Versus keeping patients healthy. So you're rewarded for healthy patients, not the number of times you see patients. It's somewhat disturbing that it took us almost 40 years to figure that out, but that has made its way into the current nomenclature. So Humana, CMS, other payers are moving to a value-based care model. The reason that's important is because the exchange of information is much more important in a value-based care model because providers need our data and we need their data. So there's some incentives from a financial perspective to start moving in this direction. I think everybody knows what CMS is. But the reason I'm calling CMS out is because they are a willing partner at the table. So I'm going to show you a slide in just a second in which Humana and CMS were standing beside each other, demonstrating interoperability with these APIs. The ONC is another federal agency. It's kind of like the CIO of the federal government, the Office of the National Coordinator for Health IT. The reason this is important is that these guys are API fanatics. So they love APIs, which is really, really good for us. And they also are starting to write regulations, which includes the Vinci Project as part of their reference implementations. I promise I'm going to define Vinci in just a second. We're going to get to that. And there's another one, the HL7 organization, Health Level 7. You might want to pay attention to these because there is going to be a pop quiz in a few minutes. And I've got goodies, guys, so let's pay attention. All right. So Health Level 7 is an organization, a standards body that Humana belongs to, along with a lot of other payers and clinical organizations, in which we basically write the rules of the road, design the APIs, and then we vote on them as an industry. Right? So it's not a government body, although it is sanctioned by the federal government. Health Level 7, HL7 as it's known for short, you're going to see it on subsequent slides, is the body that the Vinci Project runs under. So it runs under the auspices of this organization. All right, I promise I'm not going to read all of these words to you, but I'm going to describe what the Vinci Project is and why Humana is involved. Then I'm going to drop back from the definition, go through a few more slides, and then I'm going to pop this one back up because quite honestly I think it'll make more sense the second time around. The short definition of Da Vinci is a payer-led consortium of industry participants, including EHR vendors, like the software that you use when you go to, or your physician uses when you go to your doctor, defining standards for modern data exchange and interoperability. So that's important. Payer-led organization that is defining the rules of the road for interoperability between payers and providers. Typically, we are in the caboose, and this one, we're in the engine. So that's a big distinction between how things typically went in the past. The other interesting thing is that this organization was actually convened in Washington, D.C. in federal offices so that the CMS administrator and the director of the ONC wanted us to know personally that they want payers to take the initiative and drive innovation in this space. They see payer enablement as critical for the future of healthcare, which is slightly different than what we've had in the past. So it was convened under ONC for that reason, also to remove any concept of any competitive practices, right? Because if you're running under the auspices of the federal government, any competitive issues are gone. I'm not going to read the second one. You're going to read that as a homework assignment. But I will talk about the last one and why Humana is so jazzed up about this, right? Humana for many years has been a leader in interoperability, even before it was the cool thing to do. When ValueBased Care was just coming out, we started to get into interoperability. We stumbled many times. We fell flat on our face many times. But at least we kept a competitive advantage and kept the company moving forward. So many of the things that we've been trying to champion for years are really starting to come to fruition. So as wanting to maintain our leadership position, not only for Humana, but more importantly for our members and providers, we're actively engaged in this body. As a matter of fact, I've got some dramatic props that I'm going to go ahead and show you one of them. So when anybody asks me if Humana is a member of the Da Vinci Project, I whip this out of my backpack. Yes, we are. We're actually a founding member, so we had the first meeting, right? You want to take a picture? Go ahead. All right, so let's not forget that Humana is part and parcel. We have voting rights. We have a member, Mike Funk, who is in our provider area, is on the steering committee of Da Vinci, and I sit on the coordinating committee and do a lot of the technical work. Okay, who and what, right? I know this slide it's not too hard to see. A lot of people or a lot of companies up there which historically have been considered either partners or competitors, but you'll see that Anthem, the Blues, Optum, United, Humana's right here. We actually should be on the top row. This is a little bit of a note slide. Some of the premier EMR systems, Epic, Allscripts, CMS is on here. We all know what HL7 is because we just went through that a second ago. Some big medical centers, some software vendors, and that's what the landscape looks like, right? So those are the groups that are coming together to help solve these interoperability issues. Before I go much further, I want to make sure that, again, my telepathy doesn't always work as well as it should, is that I want to make sure that everybody understands that in the interoperability or integration between payers, like Humana, and providers, it's not the best experience in the world, historically. Hopefully that doesn't surprise anybody. Please raise your hand if that surprises you. Or if you're too embarrassed, just put it up a little bit, right? But historically, this has been a major issue in the sense that we have abrasion in our systems that calls providers to go different ways. They'll call the call center and ask as opposed to going to Humana.com. Since historically the APIs did not break directly in their workflow, they would jump to a web portal. Yes, I did say web portal as in 1999 type web portal to do authorizations and eligibility checks and stuff like that. Those are the things we're trying to yank out of the system so that it's an Amazon-like experience. You're in your workflow, right? You're in Amazon, you want to order some shoes, you don't call your bank or log into your bank to make sure you got $49 in there. Guess what? We've got an API for that. You don't call UPS to make sure they can ship it. We've got an API for that. You don't call the warehouse to make sure that's in stock. We've got an API for that. In healthcare, it's the opposite. You go to each one of those to make sure you make that connection. What we're trying to do with this initiative is remove that. All right, so make sure everybody understands that. Okay, so use cases. This is where it gets pretty cool. One of the interesting things about Da Vinci is that it helps us solve things that have been around for many, many years, like prior authorization. Who knows what prior authorization is? Yes, Paul, I'm sure you do, because you test it like 14 times a day. Prior authorization is a significant abrasion point. If you want to get approval from Humana for an X-ray or a blood test or whatever, it typically takes about 17 minutes for a referral coordinator, I can't talk today, to log into Availity and use that classic, maybe 2001, probably not 1999, but 2001 web portal to figure out if prior authorization is needed. And if that doesn't work, they call CIT, and they talk for 25 minutes. And if that doesn't work, they just do one out of frustration and hope it gets paid, right? So those are the type of things we're trying to deal with. Now, from a use case perspective, the project has been going on for about 1.5 years. So the first two, the brown ones up there, data exchange for quality measures and coverage requirements discovery, very creative names. They really just mean that we have built applications and APIs, prototypes, right? We've built implementation guides and reference architecture that allows us to serve that information up directly in the workflow, right? When you're getting ready to order a home oxygen therapy, Humana is going to give you a message that says, oh, we don't require prior authorization, but we are going to be looking for this diagnosis code, that type of thing. Data exchange for quality measures means that when you leave your physician's office, as opposed to Humana sending somebody out to make photocopies of your medical records, that wasn't a misquote. We do send people out to make photocopies of your medical records. This guy in the front here gets what I'm saying, so this is good. You may get a prize, sir. Then we use an API to send that information back in real time. Those are the types of things that we're dealing with. So those are very brick and mortar use cases, things that have been abrasion points for years and years and years. The other ones, which are in development, meaning we meet several times a week, we go through use cases, we write implementation guides, and then we take them through that HL7 process, which I mentioned a second ago. They get voted on, they go through a vetting process, then they're published for general use. So some of the others that we're working on are talking about prior authorization, gaps in care documentation. Anybody here gaps in care? Any HEDIS and STARS folks? Yes. So you guys are going to be excited by this. I've been trying to get Glenn Rayleigh to listen to this presentation for 3 months. You need to help me on this. Other things, risk-based contract member identification, things that really remove abrasion from provider workflow, right? And therefore make the provider happier and the member happier. I'm not going to go specifically into use cases because I could talk for the rest of the day, and I'm sure you don't want that, and you would still have questions about it. So this is going to be a topical overview, and then we can always come back for more information. All right, so here's our first pop quiz. It'll be the easiest of the day. Now, I'm going to tell you, I've got some pretty cool stuff up here. Check this, man. Humana green headband, all right? It looks cheap and cheesy, but it's not. It's really high quality. I've got some FHIR, Da Vinci, fake baseballs, and Da Vinci shirts. Unfortunately, I only have 2 sizes, small, women's small, and men's extra, extra large, 10 size. But don't let that deter you from the pop quiz. All right, ready to go? Who in the room can give me a 20 words or less description of HL7? Okay, we're pausing here. information.
Also, it's the governing body, international governing body that sets standards.
Good answer. What would you like for your prize, Paul?
Pick one.
Since I've always wanted to throw something at you, here you go, buddy. All right. First pop quiz under our belts. Make it a lot easier after that. All right, a brief history of healthcare interoperability. I'm going to go through this quickly because some of you, maybe probably not so much on this side of the room because they've heard me talk about this, are wondering why would we possibly have these issues in healthcare with interoperability? Amazon doesn't have them. Banking industry solved it years ago. Why do we have these issues in healthcare? Who's doing it? Chris, how are we doing on time?
Oh, we're good.
We're good? All right. So just keep me honest because I can talk for days on this stuff. Interoperability in healthcare has historically not been easy. And the reason for that is not the technology. It's been the business models or the disincentives to interoperability, right? So the first entry or the first, mountain taking was 20 years ago when the HIPAA regulations first came out in 1998. And we started implementing standard transactions, right? I'm going old school on you guys. Some of you may have not been born when we went through this, but the fact that prior to that time, claims and referrals and eligibility were not standard transactions. There was one for Humana, there was one for United, there was one for Cigna, for God's sake. And if you wanted to check with a payer, you had a special transaction to go to that payer. HIPAA regulations said, no, you guys got to figure that out. So we figured that out. We implemented the first level of interoperability in 2000, right? 2001, something like that, which still runs to this day. You don't hear about it much anymore because it's a very mature technology. It runs on an older transaction set called X12, which I promise I'm not going to talk about. Bill's looked at some of it about a year ago and he's still suffering the consequences. But that model works day up, lights out. We do about 1.5 million transactions, or about 10 transactions per second as a company with claims processing, eligibility checks, referrals and authorizations. You go to your doctor, they ask for your card, it does one of these transactions in real time, respond back and say, hey, Antonio has this coverage, blah, 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 right? Those are administrative transactions, which mean they were meant to run the payer business. Claims, authorizations, referrals, eligibility checks, classic administrative transactions. Not even thinking about clinical stuff at this point. This was 20 years ago. We were still using web portals, guys. So it was, a very different world. We also had a clearinghouse model. Anybody know what don't answer this question. Anybody know what Availity is here? Heard of Availity? Yes, Stan Gaines knows what Availity is. A lot of folks. It basically borrowed from the banking industry so that we could use a clearinghouse model so that payers, so that they didn't have to connect directly to Humana and then Cigna and Aetna, can go to a single place, and then Availity brokers that communication to Humana. Still runs today. Very good model, right? But again, it was an administrative transaction set, almost like a banking model. Then, in 2010, I've got more dramatic pops here, we started to get into clinical interaction. This is the reason why. I've kept this on my desks for 9 years because this was the document that moved Humana into the clinical interoperability space. I know you can't really read this, so I'm going to read it for you. It basically says the report to the President realizing the full potential of health information technology and to improve healthcare for Americans. The path forward. Right? So somebody threw this on my desk 9 years ago and said, hey, I don't have time. Go read this and do a response back to AHIP, the American Association of Healthcare Plans. Right? So I looked through it, wrote a quick summary, and I thought, we should talk about this because if we can start doing clinical interoperability, the landscape changes. If we have better information clinically on our patients, we can run better analytics, and if we can send information back, like gaps in care or other things, HEDIS measures that folks need to be operating on directly in the workflow, our patients become much more healthier, our providers much happier, right? And so we started down the journey that long ago. It wasn't just me, it's an entire time of folks, but so that's how we got started down the path, right? And about 3 years after that, we started talking about FHIR, right? Which all the cool kids know what FHIR is today. If you don't know what FHIR is, keep it to yourself during this meeting. Call me afterwards and I'll give you a lesson on FHIR. Just kidding, we're going to go through a quick session on FHIR in just a second. But that technology, which is very new 5, 6, 7 years ago, is the foundation of interoperability today. Am I right, Jason?
Absolutely.
Right. So
Patrick, are you Apple ready?
Apple ready, bro. Apple ready. All right. So I would love to show you this old document from 2000, but I'm just going to skip it. And it's 71 pages long to tell people how to figure out if a patient is a member. So I'm trying to draw a discrepancy between the way that we deal with FHIR, which is the latest version of HL7 standard, versus some of the previous standards. And I'm not making this up. In the previous model of clinical interoperability, which we were doing 10 to 15 years ago, we were using an industry standard called HL7 version 2. I've got other names for it, but I can't say it on tape here. And it literally, the sequence diagrams for the technical folks in the room were so complex, it would take 70 pages to document an interaction to determine if Ann Gaines was a Humana member. So we're not going to go into that detail. If you want to talk afterwards, we can. As opposed to the new model, the RESTful API model is, hey, you know who Ann Gaines is? Yes, right? Very different approach. Now, why did it take us so long to get to this? And we hinted at it a second ago, the disincentives. Because, unfortunately, some of the clinical EHR systems compete based upon the audience that they can, I'm trying to choose the right words here. Sharing clinical information between competitors doesn't come natural to the ecosystem. It sounds very intuitive. If, I'm going to pick on Ann because she's chomping down back there, but if you go from one physician to another, it makes sense that your medical records should go. But if the provider 1 and provider 2 are using different EHR systems, there's not a strong financial incentive for that EHR system to automatically send the information over. They would much rather go to provider number 2 and say, oh, just buy our software. Then you can talk, you're on one big system and information flows freely. Right? So the model was actually the opposite of sharing. It was one of buy our product. That started changing about 10 years ago with some of the federal regulations in which folks were required to support porting these APIs. And that's where we come to today's model, in which people have jumped on the bandwagon. Da Vinci is up and running, and we're now beyond just talking about it. We're actually creating reference notations. We're building software to make some of this happen. Value-based care, which I mentioned a second ago, was critical because, I'll get that in a second, we're going to talk about the inflection point. I know that most folks in this room understand what an API is, especially over here. So Jason, go to sleep for just a second. But for the purpose of discussion here, if you're not familiar with API technology, the only thing you need to remember that an API is a little software program or component that allows two systems to talk to each other, right? To send information, to get information, to put or get, right? Another dramatic problem. Your phone can only communicate via APIs. When you do banking, Facebook, whatever, those are APIs that are sending information back and forth. I know that seems very mundane, but it's going to be important when I get to the next slide. Companies such as Amazon, Netflix, Google, Facebook, all of these guys are completely API-based, right? That's why, when I used the example earlier of buying shoes, I think it was, it's such a seamless experience because APIs behind the scenes are making all of that happen. Right, Holly?
Yes.
Yes, exactly. Thank you, Holly. And we want to get that way in healthcare so that when somebody's in their EHR system, those APIs are putting and getting information pertinent to that point in time. That's why APIs are important here. FHIR. So FHIR, which is taken almost a mystic proportion these days, right? Because you'll hear that our executive leadership talk about it. There's articles all the time on LinkedIn. Administrator Verma, the CMS head, talks about it consistently. Dr. Rucker, the head of the UNC, talks about it consistently. FHIR is nothing more than an API that has been tuned for healthcare. Right? It means we have agreed what a claims look like, or a claim looks like from a transaction perspective, or what a patient looks like, or what an organization or whatever. It just means that we've all agreed as an industry, we voted on these, we now agree that we're going to use these protocols when we exchange information. Versus the 71-page document that I was going to show you, but I held off. Your own health benefit, right? So this is the beauty of FHIR. It defines the API and the data that goes back and forth. Any questions on FHIR? Even if you're bored with Da Vinci, make sure you understand FHIR when you go back to your desk. Not only will it impress your family and friends, you're going to hear more about this as time marches forward because it is the de facto standard for interoperability. All right, so why now? Why is Da Vinci, why are other things coming up or becoming so prominent in today's world? APIs are available, right? The e-commerce area has been using it for many, many years, and we now have a standard in healthcare for API technology. That's critical. The federal government is strongly supportive of API technology and Da Vinci because they see it as a way to solve not only the problems of payers like Humana, but also CMS in general. So who's the biggest consumer of healthcare in the world? This is a really easy question, by the way. CMS. And I can't even remember, it's $3 billion a day, something enormous. So the federal government is the biggest consumer of healthcare costs in the US, so they want to solve these problems as much as we do. So in the regulations they're proposing, they mention FHIR technology. Considering that we are a Medicare Advantage company, hopefully that's not news to anybody in the room here, it behooves us very much to be moving in that same direction. The good thing about it, we were moving in that direction before they were, so it's all very beneficial. CMS, and Jason and others, Sean, I know this very well, of course Antonio, that CMS started implementing these FHIR transactions and FHIR APIs a year ago. We've actually built applications on top of that in deck. So really, really cool stuff there. And they're just easier ways to develop software, right? You build them once, you reuse them anywhere, use microservice patterns, things just become easier. So the way that we describe this is there is an inflection point. Federal government, industry cooperation, technology, I know this is not a circle, I'm not sure what I'm drawing here, but somewhere in here is basically I can't say black hole, but it's probably a little bit negative, is a gravity well in which these things are starting to really drive innovation. All right, everybody ready for a pop quiz? I'll make these questions up on the fly, by the way, so you really can't lose. All right, so who in the room here can give me a 20-word or less description of FHIR?
Standardizing policy procedures for quick and redeployable interoperability standards.
Yes, I was going to reject your response, but since you used API, you win. All right, what would you like to have, sir? I've got a baseball, I've got a shirt, headband. Wow, I didn't think that was going to be able to get that away, so thank you. All right, that's a really good pub quiz. Smart on FHIR, I'm going to cover this really quickly. How much time we got left, Chris?
20 minutes.
20 minutes, we got to pick up steam. Smart on FHIR, we talked about FHIR. It's basically an API technology that allows two systems or applications to share information, right? Humana and an EHR system, for example. Smart on FHIR is a technology that allows folks to build applications on top of FHIR, right? Because FHIR is not human readable. Well, you can if you're an engineer, but you don't want to spend all day reading FHIR. If that can be converted into an app, or an app talks FHIR, you've got a real user interface, right? Either on your phone or directly in the EHR system or whatever the case may be. So Smart is, again, another level of innovation. We had APIs and we have FHIR. Now we have Smart. And now we have apps on Smart. All right. Workflow integration. That's just an example of a Smart app prototype that we built and demoed. Here's the beauty. I know this is a really basic slide, but to see how Smart and FHIR bring information into a workflow, right? So Cerner, in case you're wondering, is a large EHR system, right? I don't know exactly what percentage of the market they have, but it's a very prominent EHR system. So if you go to the hospital, you go to your doctor office or whatever, there's more than a 25% chance they're going to be running Cerner behind the scenes, right? And then we have Humana on the other side, because of course you're a Humana member. If we build applications, meaning Humana, or third party, or Apple, or whatever the case may be, that can interact with both Humana and the EHR at the same time. Think how powerful that is. So you can get clinical information out of here, like diagnosis codes, medications, whatever the case may be, and you can also get information from Humana, coverage, referrals, authorizations, gaps in care, HEDIS and STARS, things the physician really needs to know to provide the best health care. Because hopefully this is not a big secret, but in many cases, Humana and other payers have more information on patients than their own specialists do, especially if it's their first visit. right? So the power of having a little app, we all take for granted, right? But this is revolutionary in the sense that if it's running inside of an EHR, communicating with both at the same time, we've just circled the moon as far as advancement in interoperability.
Imagine going to a doctor that don't ask you the medications you're on.
Imagine that, yeah. I know that sounds basic, but she's not joking. I mean, she's actually, you know, we hire pharmacists to do nothing but call people and ask what medications they're on. Yes, I didn't know that. But, so, actually, I know you guys built OML, so you probably are very much aware of this. All right. Okay, I feel a pop quiz going on. You ready? I don't have a good question. What do you think? Who in the room, this is going to be the easiest one I'm almost embarrassed, can give me a 20-word or less description of SMART?
Innovation specification that allows the ability to build apps on top of FHIR.
That is the best definition I've ever heard. Yes. Excellent. And I may have something you're interested in.
Yeah, I want to share.
You want this shirt?
Yeah.
Okay, well, let me just give it to you then. All right, there you go. Cool, you're welcome. By the way, those are the shirts that we use when we demoed some of this software down at Big Conference a couple of weeks ago. All right, so quickly back to the definition. Hopefully this makes more sense now. We talked about the technology, we talked a little bit about the use cases. So as an industry, we've agreed on what APIs look like, what the payload and the content looks like, and now we can start sharing information, right? Really driving results via interoperability. Does this make more sense now? Somebody please. All right, Da Vinci, right? Everybody has a pretty good idea what Da Vinci is. We've got some use cases and stuff like that. How does it fit into the broader ecosystem? This is where it gets really cool. Because in the old days, as an industry, we would never have seen this slide before because we would have done it in silos and somebody would have worked on this side, somebody on this side. We would not even know these things were coming together. But we have several organizations. This is the one we were talking about for today, which is payer and provider interoperability, right? Hopefully, you've got nothing else from today, you picked up on that, right? Yes, okay, some interaction. There are other projects very similar called Karen, by the way, which some of us in the room were on a call the other day with a big third-party app developer, the biggest third-party app developer and hardware developer, in which we're using the same technology, FHIR services, to get members directly on their phones. Right? So not only can a doctor use FHIR and Smart on FHIR, it's running on your device. You need to get Humana's records, you get here. You need to send medical records from Humana to your specialist. You're seeing for the first time when you click here. Right? Same underlying technology, but it has enabled another part of the ecosystem, the consumer experience. Right? Provider to provider, I'm not going to spend much time on that. But that's a given. But these two things working together become very, very powerful. Historically, payers have operated in this space, payer to provider, using classic 1991 consent models, right, health plan operations. But with consumers in the middle here, giving consumer-mediated healthcare like Blue Button, that opens up a whole new frontier. So use cases and applications that were possible under the older consent models are now enabled with the consumer in the middle there, right? And then we got a big initiative up here called FAST, FHIR at Scale Task Force, which I participate in as well, is to make sure this stuff can run, hundreds of millions of transactions per day. I'm not going to go much into that, but there's some pretty cool technology behind that. Does this make sense?
Yep.
Okay, cool. All right, Chris, how much time we got?
20 minutes.
20 minutes? Okay.
15, 20, yeah. It's 12:40, I'll tell you.
12:40. Got it. So now that we have, I think, hopefully a good foundational understanding, and you've got, a belly full of pizza. The good thing about presenting here is even if I totally flop, you get pizza, and you're going to go home smiling anyway. So, is some of the documentation that we have. So I'm going to just quickly jump into some of this, and you can certainly, I guess this presentation gets sent out, Chris, but if you want to learn more about the use cases, then we can jump over here. And we have, under the HL7, everybody remembers what that is, the Da Vinci use cases, right? So we talk
Who
about here.
offers this?
This is authored by teams with Humana participates in. We author them as a group. Sorry, I can't do that with the mic. They go through a balloting process, then we vote on these, and then they're moved into a pipeline for delivery. Yeah. So these are the ones that we've talked about before. Going down. Coverage requirements discovery, documentation templates and coverage rules. I know these are really cryptic names, but they're actually pretty cool stuff. This one allows us to ask a physician, what's your name, sir?
Jared.
Jared. Well, Jared is at his doctor's office, right? With these APIs and this reference guide, we can ask a specific question of the doctor about Jared. Like, for example, hey, doctor, you're ordering an x-ray for Jared. Did you know he had one last Tuesday? Or, hey, while Jared's in there, I don't mean to pick on you, sir. While Jared's in there, you might want to mention the fact that he was supposed to have had this exam last year, but he didn't, right? So those are the types of things we're able to do. Prior authorization, you get the idea. There's an important one for the HEDIS and STARS folks in the room, right? Okay. Let's go back over here, and this is all freely available. Implementation guides, I do want to give you a flavor of the output of the group, right? We have basically two flavors of output. We create implementation guides, and we also create reference architectures. And then we do what we call a connect-a-thon, meaning we all go to a city, we hook up all of our servers in the cloud, and we test transactions back and forth, and completely geek out for a couple days. All right, so this is a very colorful implementation guide for one of the use cases that I talked about earlier. I promise I'm not going to read this material for you. There could be a pop question on it, pop quiz, but these are the types of things that come out of this, right? It can be very dry, some nice graphics explaining how it works. And the purpose of this is that anybody, even if you're not a member of Da Vinci, and Humana is, in case anybody forgot, founding member, just make sure you got that, that you can take this implementation guide and put it in your system. No charge, right? Completely open source. You can go into GitHub, download some reference code, right? Test it on your system, because at the end of the day, we're trying to drive a better patient-provider experience. Remove these goofy aberrations that we have in the ecosystem so that people get better care. That's the goal of the initiative. So this is the output. I promise I'm not going to go into the source code control, but these are the types of things that come out of this, right? People can download it, implement it, be certified as, following the standards, and life becomes good. I think I've got one more. For the really technical people in here, and I've got to go into GitHub, sorry. If you want to actually get in there and look at, some of the GitHub stuff, this is where we actually go in and download the source code, run it, whatever the case may be. And you can get a feel for what it looks like to test these implementations. About 3 times a year, like I said before, we'll meet and do a connect-a-thon, make sure all the APIs are working and that type of thing. Now, I promise we'll leave some time for questions. Oh, here's a connect-a-thon right here. This is where we tested some of this interoperability a couple of months ago using a clinical model in which we had a patient named Dara, right? And then we would all sit at one of these 4 stations, right? Humana, Aetna, CMS, Epic, all scripts. And then we test the transactions back and forth in front of a live audience. And they'd stop, and you'd switch stations. And you go back and forth. So it's a little bit of a meritocracy as far as proving that you can do this stuff. I'm very proud to say Humana was the only payer that was able to represent all 4 use cases. So I felt pretty good about that. I think there's some folks in the room. Credit to the people in the room. Credit to the people in the room. The joint effort. And there is sort of an example of a live demo. I don't know that I have time to walk through all of these use cases. How much time we got? We've had 15 minutes for like the last 45 minutes.
Patrick, you're like, are we there yet?
Yeah. I'm going to keep going. Can you order some more pizza? All right, I'm going to quickly walk through these use cases, then I'm going to open it up to questions, right? So, some of the things there were, because I can give you coverage requirements, discovery, document or quality reports, you're like, that sounds great, what does it really mean? This is one that drove it home, right? The fact that in today's world, and you know this because you did research on it when you were in the Innovation Center. Don't give me that look, you know what I'm talking about. In the sense that if a patient goes to her PCP and he refers her to a cardiologist. Ah, well, that's a problem. I don't know who's in network for Humana, and I have no clue how to schedule an appointment. You're on your own. As opposed to an interaction in which the PCP EHR system sends a message to our scheduling app. Right? The scheduling app looks at the network and the quality data, CDI information, and say, oh, I got a recommendation on this. It's going to be Dr. Grace Hopper. Hopefully you guys get that analogy.
Yeah.
Jason. Grace Hopper, the first thing it does, using FHIR APIs, negotiates with the EHR to make sure that we know who the right patient is. It then looks to see what slots are available, books the confirmation, and then Dara shows up, the patient, and has her cardiology appointment. Right? So think of the reduction in abrasion based upon that model. The second one is, and I'm not making this up, it happens all the time. Do we have any clinicians in the room? Any physicians? Anybody that wanted to be a physician when they were a little kid? In this model, you have a specialist, a cardiologist, right? Dara shows up. He may have gotten a phone call from the PCP's office. They may have faxed something. There's more than a slight likelihood that it's a cold call. He knows that she's got chest pain, but he knows nothing more. So in that case, there's an event that fires inside of the EHR called a CDS hook. And the CDS hook pings Humana with the FHIR API and says, hey, patient Dara is here. Do you have any information on her? Because I really don't know what's going on. And Humana, since we have all the claims, all the referrals, authorizations, they will say, oh yeah, she's one of our patients. We look at, I know it's hard to see, but it's, claims, labs, all that kind of stuff. It says, yeah, we can provide you with some information. So we use FHIR, because everybody knows what FHIR is, to send the information back, right? And it arrives directly in the EHR, and the specialist reviews it before he starts checking her symptomology. So it's not so much of a cold call. Yes, Chris?
How long is this? Like, what's that latency right there?
234 milliseconds. Give or take. No, it actually is roughly that. Yeah. Now, total transparency. These were APIs using synthetic data. None of this is connected to our backend systems yet. That's this year's initiative. What I'm showing here was just testing the APIs using synthetic data. All right. The next one is Dara goes to the hospital. They want to do a couple of checking because she has unstable or stable angina. Make sure she's okay. She goes in. The hospital physician checks her out. They run a test. Yeah, you're okay. But we want to send you home with home oxygen, just for a couple of days. Oh, wait a minute. Is the payer going to take care of that? They need anything special to make sure she gets home oxygen therapy. But we got a FHIR after that, or a FHIR API that says, hey, we're getting ready to order some equipment. Send the transaction and make sure we know who Dara is. Check some of our coverage and plan rules and says, yep. We're going to respond back with a coverage requirements message in real time that says, Dara is a Humana Medicare Advantage patient, right? Home oxygen therapy requirements, that we need a diagnosis for supplemental oxygen, because if you send us or stub your toe, we're not going to pay for home oxygen therapy, and also tested to confirm hypoxia. Right? I got that from our actual guidelines. But prior authorization is not required, so don't go log into that 2001 web portal and spend 18 minutes doing an authorization that's not needed. So we may have eliminated 25 minutes of painful, unfortunate, disturbing, inadequate workflow with one API. Was that a pretty good description, Shrek?
That was good. Disturbing and inadequate together.
I could probably think about this too. Okay, the next one, you guys need to listen to this. Glenn has seen this, but he needs to hear it from you as well. Physician is doing a 30-day med reconciliation, meaning that post-discharge, meds have to be reconciled in 30 days, right? So Dara goes back to her PCP. He's going to check her medications anyway. That's his job as a physician. But Humana needs to get access to that. In today's world, we do that by waiting for claims to come in and trying to figure out using advanced algorithms if we can figure out the medication list based upon the claims. That's the efficient model. The inefficient model is, guess what? Somebody drives out to the doctor's office, opens up the Canon copy machine, puts a copy on there, does it. I'm not making that up, by the way. Chart chase, yes, chart chase. It still happens in 2019. In this model, guess what? It's better though. When the provider closes the record and it's EHR, it says, yep, I agree with this. The EHR knows that it needs to communicate with Humana. Because guess what? There's a financial incentive for this as well. If we get that information back, we can prove to CMS we're taking really good care of our patients. Doctor gets paid more. So he or she's on board with that, right? Comes over, goes into HEDIS and STARS, right? Supplemental file, wherever you guys want it, right? It wakes its way into the internal engines which do the analytics on this stuff. Then it goes into a nice advanced analytic database, and we may be able to provide some additional messages back based upon the medication, say drug-to-drug interaction, whatever the case may be. The bottom line is, it's much better than Chart-Chase. Not that we don't like people who do Chart-Chase, but considering how inefficient, how costly it is, and it's just not a good model. All right, I think we've got, I'm going to do one more pop quiz, and then we're going to stop and take questions. 15 minutes still? 10 minutes, okay. I was going to get worried. All right.
Hey, Patrick, we have something for you first. Just one of
All
our,
right, I like these for me.
one of our deck design shirts, so you enjoy
Sweet.
that, wear it home. Should
Thank you very much.
Question with the group.
Is that a women's small?
No.
It would be appropriate. All right, thank you very much, guys.
That's my favorite shirt. I
I
love
bet
it.
it looks good on you, man.
You too.
All right, so pop quiz. I'm thinking of a really hard question as I. All right, I got an easy one for you. Who in 20 words or less, I'll give you 25 words on this one. Who in 25 words or less can give me a description of the Vinci Project? Come on, I'm sure this is the last one.
So, from what I understood, the Vinci Code, it's a project where they put all the proprietors, the years of work in the healthcare system to identify a way to set up a set of rules in which they can communicate and interpolate data between different systems so that there are standards, communications, and response to all different types of health questions.
In real time, right?
In real time.
All right. Don't let get a present. What would you like? You got a fake baseball or extra large tent size shirt? You probably get yourself and a couple of your friends in there. So. All right, thank you. Well, since you're going to donate it, you get 2 prizes. Okay, so I am done with the official presentation. Any questions, comments? Yes, Brad.
You said interoperability, which makes me think between companies, right? What about internal FHIR? Internal.
That is a great question, Brad. And so that leads into a topic of FHIR internal to the organization, which we have an initiative underway to make that happen. So, to give you a little bit of background, FHIR was initially designed, I shouldn't say that, it was designed for a very broad purpose. The initial implementation case, even predating Da Vinci, was for company to company or entity to entity interoperability, payer, provider, whatever the case may be. The cool thing about FHIR, and I know you guys are going to rush to get back to your desk to look up FHIR and go, I'm getting any work done today because you'll be doing all this FHIR research and that type of thing, is that it also has a really good data model built into it, right? So it's already defined medication list, it's defined encounters, it's defined communication protocols. So some of the use cases are starting to find their way internally. So what Brad, I think, is referring to, at least I'm interpreting as referring to, is the fact that we are building a common core, what we call the common core, which is an internal messaging system, API system, that allows us to use FHIR to go between platforms. For example, between the Edge, our new health plan, and classic Humana, or between our at-home platform and our care delivery organization. So FHIR, not by mandate, but by decision, was initially meant only for interoperability across the internet. It's now finding its way into internal use cases as well. Good question, Brad. Next question.
This is more a curiosity question for me. So, I'm assuming that there's some sort of level of authentication and security protocols that must be followed in order to collect data from the FHIR system.
Yes.
And
Is there also some sort of, like, what are the requirements for someone, let's say, to do a startup, wanted to do some analytics on the data, and to collect it, like, what were some of the requirements to get that started, to be able to access FHIR data?
So that's a good question, and I think the security is handled by OAuth and OpenID and that type of thing. As far as consent, that's where it goes from technical to legal. So, and Jason and I have had a lot of interesting meetings about this, in the sense that, and I mentioned this earlier, in the payer model today, most of our consent is based upon classic payer consent models. Either it's under health plan operations, meaning we can give data to a third party as long as they're operating on our behalf, right? But the patient has a mechanism for opting out, right? In the blue button model, which CMS implemented back in March of last year, is the patient has to give specific consent for the release of that information for the purposes defined within the consent document, right? The consent models for what we saw with Da Vinci, for the most part, run under the classic payer interoperability model, meaning we were providing information for the benefit of the provider or the member. And when you enroll in Humana plans, you get 30 days to opt out of all of this. Nobody even should say that. Most people allow us to do that type of, don't opt out for that. But there is a lot of work happening in the industry on what the next generation of consent's going to look like. So the current use cases are able to operate on the previous model or the existing model. Those advanced use cases are going to require some work.
Is consent part of the FHIR standard? Does it need to be, or is it?
Technical consent is. So the technical, the authorization and authentication is part of the standard. Getting consent or determining what consent model should be used is not part of the Da Vinci. Yeah, it's a level above from there. Sure. Any other questions? 15 minutes still, Chris?
Oh.
No?
Two.